Good afternoon. My name is Nicholas Katz, and I'm a first-year AA student at NSU Tampa. I'm here to speak to you today about an unfortunate overlap of two mysterious fields, anesthesia and our immune system. So the abstract or big picture of my presentation today is to say that optimal immune function and optimal anesthesia are pretty much mutually exclusive terms. There do exist methods, however, to balance the benefits of each, but I don't think that they're talked about enough as they should be. And it's understandable why this is the case. It's perceived to be expensive, patient compliance becomes a factor, and it looks effort intensive, at least from the outside looking in. So what this review aims to do is break down each component of our anesthetic to see their effects on the immune system, both good and bad, and the mechanisms by which they do it. The learning goal today is to make evidence-based conclusions to maximize both surgical and immunological outcomes. So just to give an example of the immunosuppression that we give our patients on a daily basis when we do anesthesia, let's look at midazolam. So midazolam suppresses monocyte function even in single low-dose injections of three very important pro-inflammatory molecules, all three of which are implicated in fighting infection. So when you combine this with three separate factors, the stress and trauma of surgery, which releases immunosuppressive glucocorticoids and catecholamines, the increased risk of infection from being a patient in a hospital or getting a nosocomial infection, and lastly, the increased prevalence of drug-resistant pathogens, you get what sounds like on paper at least to be a recipe for disaster. And this is just the first drug that we often give. What about the rest of the drugs that we often give during our anesthetic? Well, the bad news is that our anesthetics are dirty. And what I mean by that is that they have multiple sites of action that are often unintended from their initial site of action that we learn about in the textbooks. Especially our volatiles, because they act on our immune cells, which have implications for increased tumor recurrence, higher rates of infection, and postoperative cognitive dysfunction. However, luckily we can fight some of these effects with something called enhanced recovery after surgery protocols, or ERAS protocols. And I'll be talking about ERAS protocols a lot today because they happen to overlap very well with preserving patients' immune function. That's partially why they work so well. So let's look at the data. This paper looked at gynecologic oncology patients who are undergoing the laparotomy. And you'll note that the ERAS patients, the ERAS cohort, spent less time in the hospital, had less post-op morbidity, fewer incidences of ileus, and a lower pain score than non-ERAS patients for the same surgery. And if you aren't familiar with what ERAS protocols entail, I'll be talking about that today too. So you might look at this data and think that it's expensive to use these protocols on these patients, but literature has also proven that to be false too. So Gentry 2020 says that ERAS for this previous cohort of patients that I mentioned does not lead to an increased cost for the hospital system and actually reduces the length of stay, which creates the capacity for more cases down the line. So economically speaking, it's actually favorable if you want to take that approach about looking at it. Stone in 2016 found that with financial models, data, and experience, the projection is that ERAS programs can actually lead to net financial savings for U.S. hospitals. So with these benefits in mind, what is recommended to maintain patients' immune function? Or another way to think about it is if it were you or your own family going under the knife, what preferences would you have? So here are some recommendations. Preoperative. So a good complete diet 2 weeks before surgery at least is imperative, including foods that are rich in iron and vitamins A, C, and D, for the reasons I have listed here, and also carbohydrate-rich drinks up to 2 hours before surgery. And Shore actually makes a pre-surgery drink, which I didn't know until looking into all of this. These drinks help replenish the MPO deficit due to an overnight fast. Another important point is a probiotic regimen, because this helps bolster our gut microbiota, which are crucial to immunocompetency and preventing ileus. Operatively, some more considerations are that laparoscopic surgery is preferable to open surgery. This is because of reduced surgery duration and reduced blood loss, risk of needing transfusion, and risk of GVHD, cytomegalovirus, etc. Rigid euvolemia should also be employed, and we should spare opioids wherever possible, and if that's not feasible, use synthetic opioids. The reason for this is that stimulated opioid receptors lead to the production of ACTH and glucocorticoids. Glucocorticoids are known immune suppressants. So when our sympathetic nervous system is activated, we also release catecholamines, which are known to also suppress functions of our immune cells, such as lymphocytes, natural killer cells, and macrophages. Interestingly enough, the mu, delta, and kappa receptors that we know are present in our nervous system are also present on our immune cells. And studies have found that because of this, opioids such as morphine can trigger apoptosis or program cell death in T lymphocytes because of the presence of these receptors. Now, with synthetic opioids, this effect is not seen. However, there's still the aspect of ileus and gastrointestinal problems as a result, which lengthens hospital stay. So in order to supplement this, regional anesthesia and neuroaxial blockade should be used as much as possible. This helps suppress the neuroendocrine response and therefore reduces immunosuppression. And we also know that TIVA, total IV anesthesia techniques, suppress the immune system less than a general anesthetic with a volatile agent. There's less associated nausea and vomiting, and the literature has shown that in terms of protecting circulating lymphocytes, propofol is superior to sevoflurane, where VAs cause a high release of plasma catecholamines and glucocorticoids than does a TIVA technique. So postoperatively, some recommendations are to continue that immune-enhancing diet that I mentioned before, but with fatty acids, arginine, and glutamine. This helps reduce anti-inflammatory markers, improves the rate of wound healing, and supports T-cell maturation and gut mucosa. We should also raise the head of the bed 30 degrees if we think that our patient is intubated after surgery. This helps reduce the likelihood of ventilator-associated pneumonia. And once again, continue opioid-sparing techniques with NSAIDs or neuraxial methods, such as mid-thoracic epidural anesthesia. For orthopedic procedures, early oral nutrition and swift ambulation are also important for reducing hospital stay. A lot of TKA patients I've seen are having the goal of being up and walking on postoperative day 0, which is great for recovery and immune system function. So in conclusion, surgery is really a multidisciplinary approach to correcting pathophysiology. So often, immunological considerations take a backseat to more immediate surgical priorities. And this isn't without justification, because the benefits of intervening surgically often outweigh the costs associated with immunosuppression, especially if it's just for a small period of time. However, as we've seen with recent news events, it's important to protect our immune function, and I think it's warranted to look into protecting immune function as much as possible, even if the risk associated with transiently immunosuppressing someone is small. Fortunately, though, with opioid administration becoming more scrutinized in recent years, emerging trends in anesthesia that spare these types of drugs happen to overlap nicely with preserving immune function as much as is feasible. Techniques such as TIVA with short-acting synthetic opioids, ERAS protocols with carbohydrate loading and immunonutrition, and ultrasound-based regional techniques taught to us at NOVA by the wonderful Professor Leonard. All of these factors combine to make a changing direction in anesthesia to where we're really focusing on the patient's overall health and not just their surgical problem. So in the future, I think a higher prevalence of these techniques, plus more ERAS teams composed of motivated, educated individuals in these fields, will help us better provide care in all aspects, including immunologically, not only protecting our patients, but also saving money at the same time, which is a preference of many hospital systems out in the world. So here are my references, and at this time I will also take any questions. Thank you for having me, and have a wonderful day.